So, welcome. Today we're going to talk about stress tests and are they really necessary? This is from Oliver Wyman. 8 million nuclear stress tests performed in the US each year. 8 million. And as you can see from the rest of the title, they're asking the same question that a lot of us are asking. Is that really necessary? Well, guess what happened? The number of stress tests that have been done during the COVID shutdown, the pandemic, has plummeted. And a lot of people, a lot of well-informed folks are asking the same question. If cardiac stress tests, if treadmill stress tests are that important, they're necessary to sustain life, then why have they plummeted so much? We're going to talk about this article. It was in, as you see, in the Washington Post. It was in June, mid-June, and it was written by Harlan Krumholtz. Dr. Krumholtz is a Harold Hines Professor of Medicine at Yale, and his focus is looking to see the procedures that we do. Are they really necessary, and do they really bring improved life and improved health to the patients that these are being done on? So he goes on to talk about the ISCHEMIA trial, the ORBITA trial, the COURAGE trial, different studies, global studies that have been reported recently, which again are throwing the idea of a stress test into question. Now, you have to be careful as a physician talking about this, because countless cardiologists, cardiology clinics, even heart hospitals are driven financially by this model of medicine. But again, let's take a look and see what the science actually shows us. So that's what we'll be talking about in the program today. Before we do, we'll talk about what sort of things we've covered in the recent past. One is prediabetes. If you look at our population and you understand the importance of prediabetes, it very well may be killing, and I believe strongly that it is killing a lot more people than full-blown diabetes itself. Why? There are probably anywhere between 24 and 100 people with prediabetes for every person with diabetes. Those people with prediabetes are burning their arteries, getting plaque, damaging the nerves, damaging the tissue in their eyes, getting retinopathy. All these things happen before you get a diagnosis of type 2 diabetes. So prediabetes, quote, a touch of sugar, is not just something, oh boy, well, you know, I'll worry when I get diabetes. No, you have the disease process now, and it is damaging tissues. What's very interesting, and what does this have to do with dentists? Number one, dentists see this. They get warning signs on this before doctors do quite often. And it comes in the form of bleeding gums when you go to see the dentists. Number two, as shown by the last NHANES National Health and Nutrition Surveys, it's like the census. It's part of the National Census Program. A study done in association with that showed that there are over 22 million people seeing their dentist who don't see their doctor. 22 million people that have prediabetes. So again, the CDC in reaction to this has said, you know, there's a thing called PPID program. It's an acronym. It stands for pharmacists, podiatrists, optometrists, and dentists. And saying, look, we've got a huge potential for accessing and patients, for increasing public awareness, and we're blowing it. Dentists are not making patients aware, even though they have very clear indications that the patient is setting themselves up for a heart attack, stroke, has prediabetes, has bleeding gums, but we're not training the dentists, and the dentists aren't getting involved in it. We're not reimbursing dentists for this. And even worse, most of us criticize dentists when they try to go there. So a couple of videos on that. Video on osteoarthritis. Now, rheumatoid arthritis Lupus arthritis, psoriatic arthritis, all the inflammatory arthritides cause as much increased risk for heart attack and stroke as diabetes. Most people think, well, osteoarthritis, just wear and tear on the joints, doesn't cause that much. It doesn't cause as much as the inflammatory arthritides, but it does cause, or it is very much associated with increased risk. We talked about reasons for that. A couple of the most popular videos in the recent past has to do with intermittent fasting, some of the debate in the science about that, and supplements for cardiovascular health. And again, supplements are always a very popular topic. Speaking of popularity, the Got Sugar webinar, the insulin resistance webinar is becoming more and more popular. Actually, we had one yesterday. I didn't do it justice, but still the patients, the attendees did. Major focus on looking to see, you know what, my doc is not doing an OGTT. I asked him about it. My doc doesn't know what a Kraft insulin survey is. I'd like to get a little bit better understanding. This is the way to do that. And this is the way to actually get an OGTT, oral glucose tolerance test, a Kraft insulin survey. Find out what your own status is regarding prediabetes. This reminds me that we're currently in discussions with a home lab, a lab that uses the technology, the micropipetting technology. If you can look it up, many of you may recognize the name Theranos. Elizabeth Holmes built that. She was coming out of the block, sort of like Sergey Brin and Larry Page at Google, dropping out of Stanford and creating $1 billion company. The company was called Theranos. It, I believe it had, it had one of the well-known national statesmen on the board. It was doing very, very well. And then she got put in jail. The whole thing got shut down. Here's why. She was pushing it too far, too fast. And when she did, she did some illegal stuff. Now, if you were involved with the lab industries at that time, the lab industry insiders were saying, yes, the technology is real. Micropipetting sets up a way where you can just do a finger stick and get complete blood studies. Now, it's been, what, 5 years or more since Elizabeth Holmes and Theranos blew up. But this technology, this micropipetting technology is now coming to a usable status. And so we're working with some groups to see if that's going to be a possibility for us and our patients. Very, very good timing in terms of the pandemic. We've got other webinars available. The supplements webinar, the plaque webinar. In fact, most people, one of the most common reasons for coming to see us is you have plaque. You had a positive stress test, not a positive stress test, a positive calcium score, and your doc didn't know what to do about it. We know what to do about it. So again, we can help you in that place. The courses continue to be popular. Plaque course, insulin resistance course, cardiovascular inflammation. Within 2 hours, you can know more than the vast majority of primary care doctors about insulin resistance, plaque, how to measure it, what to do about it, and cardiovascular inflammation. Now, this topic today, why are we doing so many stress tests, is coming out of a series that we're doing for the upcoming book. The book is now with the publisher. It should be out within a month, maybe 2 months at most. One of the things we do in the book is start off with the Tim Russert story. For those of you who don't know, Tim Russert was a globally known celebrity. Meet the Press. He was the host of Meet the Press, and he loved to grill people on what they were doing and did it make sense politically, and did it make sense ethically. He was getting problems with his weight. His waist was growing up to about 40 inches. He'd had some problems with his blood pressure. He went to see his doc, and they said, you know what? He and his doc decided to get a stress test. The stress test was negative. This was about, March, April time period. He went back to work, breathed a sigh of relief, had a heart attack, and died in June. And that is not that uncommon. And we're going to talk about that today in the program. About docs may know and understand. In fact, most of them do know that understand that a stress test is not going to predict a heart attack, but they do it anyway. And we'll talk about why. So again, you can find some of this information on our website. We've started adding a lot of blogs which go into a lot of the details of the science that we cover. We have a brief discussion about health literacy. Again, this is to help you start to understand that you have responsibilities for your family, for your peers, for your social groups, your church. If you're listening to this channel, your healthcare literacy is pretty high. In fact, far higher than the typical middle-ager. The baby boomers have the lowest healthcare literacy of any generation. There's a high rate of truly disconnected among the older adults. They receive healthcare information from their family members, friends, and print resources. Several age-related issues such as vision, hearing, and cognition influence their ability to pick up, read, and understand this information. Health literacy is not about reading ability alone. It's also got a lot of other dimensions, like knowing how to navigate through the internet and the web. The ability to understand numerical and risk information and to perform calculations. In other words, when we start talking about things like relative risk, what does that mean? It's becoming increasingly important to understand some of those basics of math, basics of epidemiology, to understand your risk. Now, the recommendations, again, use plain language, inform the public without using a lot of jargon. I know I'm guilty. I struggle with that. But again, that's a struggle that is worth it for all of us to the extent that we care for our family and friends. Bundle messages from various government programs together so people begin to, they know what they are up for when they're seeing stuff. Present basic information first and then get a little bit more detailed as you go deeper. Find ways to understand their skill set, the digital divide. Understand what the person you're talking to can find out and cannot find out. And again, we're doing some of this stuff too. We're working on improving the quality of our website, adding e-health tools, documents, and information that can make this critical heart-saving information available to folks. Now, as soon as Gilbert gives us the water ball, we will start talking about stress tests, and are they really that necessary? So as you remember, the front page for that article in the Washington Post was titled, "Questions Grow About the Need for Cardiac Stress Tests." And it was published on June 13th, not June 12th. For decades, cardiac stress tests have been the go-to test for detecting heart disease. Heart attacks happen when blood flow to the heart is suddenly interrupted by a clot, not by a plaque. Once you begin to understand that one fact, then you begin to understand why stress tests don't really predict heart attacks. Cardiologists treat heart attacks with medications and procedures. Stents do work if you're treating a heart attack, but 90% of stents are done for plaque, and they don't work. They don't prevent a heart attack. They can help the doctor remove a clot if you're having one. In other words, yet again, it's not the plaque It's the clot that causes the heart attack. So for people who are not in the midst of a heart attack but have a positive stress test, the usual advice was to open up those narrowed arteries, squeeze out that plaque a little bit more. And that, again, has been demonstrated with the ORBITA trial, COURAGE trial, ISCHEMIA trials, multiple trials, that's not doing the trick. The idea seems logical. If you have blockage, then spread it out, open that up. But again, all of that logic is based on the assumption that the plaque itself is slowly squeezing off the artery, and that's not what's going on. So this has led to over 8 million nuclear stress tests per year to detect blockage and invasive procedures to open and bypass those blockages. In the past couple of months, though, many elective procedures have really plummeted because of the social shutdown, the concerns, the risks associated with COVID. If stress tests were that important to protect your health, to protect you from having a heart attack, you would think that those stress tests would have continued on. Now, if you read this article in the Post, again, it's a physician. He's very well aware of what's going on, and he's making the point. Yes, some of this might just be the straw event for stress tests. There is huge financial reasons that the medical industrial complex continues to push stress tests, despite the fact that the science is becoming clearer and clearer that they don't do what we hoped they would do. So you've got the ORBITA trial, you've got the COURAGE trial, you've got these trials going on, you've got docs looking at decreased income. What do? Well, when something comes along like a pandemic, maybe you go ahead and make that change. You see, stress tests require 50% or more blockage to show a problem. 68% of heart attacks occur in people with less than 50% blockage of flow. This only leads to false negative results. So you go in, you've got a little bit of plaque. It's not enough to block the flow. You do fine on it. You go back out. That plaque happened to be, even though it was only a small amount of plaque, that plaque happened to be inflamed. It leaks back out into the blood system, causes that clot. The clot releases and stops blood flow to the heart. And that's exactly what happened to Tim Russert. I believe it was Friday the 13th of June, 2010 or 2011. 30% of positive stress tests are false positives. False positive meaning they're not going to have a heart attack. False positive stress tests unnecessarily lead patients to the cath lab. The invasive procedures that come from the cath lab are expensive and uncomfortable, and most of the time, cardiologists will go ahead and have the patient sign up to get a stent. We're about to do the cath. We're about to find out if you have plaque. While we're in there, let's just go ahead and do the stent if I think we need one. And the patient signs off for it. And again, so there you begin to see how the stress test takes the patient and the doctor down that pathway. Stress test, cath lab, angiogram, and then a stent. Plaque detected during cardiac catheterization is the reason stents are placed. While 90% of stents are placed to prevent a heart attack, multiple studies have shown that they don't do that. They don't prevent heart attacks. Evidence indicates that opening arteries as a preventive measure in people who are not experiencing a heart attack doesn't produce the benefits. In 1988, John Ambrose, who was a cardiologist at Mount Sinai in New York, all the way that far back, he and his colleagues found that heart attack often didn't occur where the blockages had been severe. They occurred in other places. Again, once you begin to understand the mechanism, it becomes clear why he found that. That was the truth. In 2007, the COURAGE trial reported the procedure to place a stent and unclog arteries failed to reduce the risk of death or heart attacks or other events. The COURAGE trial, I think, was reported in the New England Journal. And actually, the day that they announced Tim Russert's death, they talked about the COURAGE trial. In 2018, ORBITA study was done. It was actually a sham procedure. It was done in England. The human subjects reviews wouldn't let them do that in the United States. What they actually did was they took people where their docs had said, look, you've got the indications to have a stent, but we're going to do a randomized clinical trial. They took them into the surgical room. They prepped them for surgery. They even put them to sleep, but only half of them actually got the stent. The other half did not. Guess what happened? Same amount of heart attacks, whether you had the stent, whether you didn't. Now, when I launch into this, when I start talking about these studies, I usually get a lot of haters coming in and saying, you can't tell me my stent didn't work. I'm not telling you your stent didn't work. Also, I'm not telling you that stents don't help for a heart attack. If the stent is used to remove the clot during a heart attack, it absolutely helps. But that's only 10% of stents. Another place where stents can help would be they can often result in decreased significant or severe angina. But 90% of stents, again, are placed to prevent a heart attack. They don't do that. Now, in 2020, another trial was done. And up until that point, they said, well, okay, maybe stents don't prevent heart attacks, but we know that bypass surgery does. CABG, coronary artery bypass grafts. 2020, I think, again, also New England Journal. ORBITA was in, I think, Lancet. It was an English study. 2020, again, I think, in the New England Journal. They looked at stents and mostly bypass, and they found the same thing. Bypass does not prevent a heart attack. So this is a little bit deeper into the ischemia trial. Again, New England Journal, 5,179 patients, moderate to severe ischemia. In other words, restriction of blood flow to the tissues in the heart. Randomly assigned to invasive strategy, which included angiography, going to the cath lab, revascularization when feasible, in other words, stent and or bypass, or a much more initial conservative strategy, medical therapy alone. Angiography if the medical therapy failed. The outcome? In terms of death from cardiovascular causes, myocardial infarction, or hospitalization from unstable angina, heart failure, or resuscitated cardiac arrest. No difference in any of those significant areas. So the study put into the question, how valuable are bypass grafts? How valuable are stents? And therefore, how valuable is a stress test? Because you get started down this road by getting that stress test. Now, again, if you've got more interest in this topic, in this space, that's what the book's about. It'll be coming out again over the next 4 to 8 weeks. It goes into all of the different ways of predicting heart attack, measuring plaque. The title of the book is Prevention Myths, why a stress test can't predict a heart attack and what other tests can. So COVID-19, here, this gets back to that last article from the Washington Post on June 13th. How did COVID affect all this? The COVID pandemic has forced a change in practice, at least for the past few months. Some people have deferred needed tests, but there are others whose tests may no longer be useful. In the midst of one of the most dramatic reversals of practice that we have seen in a long time, this may actually be an opportunity to improve clinical care. There are still some reasons for stress testing, such as diagnosing angina, but the ischemia trial should reduce the use of treadmills and other tests. Hopefully, they will never return to their prior level of use. And according to the Washington Post, Harlan, I'm blanking on his last name, that would be a good thing to come out of the epidemic. And guess what? I guess it's pretty clear. I agree with him. We're just going to show 10 seconds of this. This is choosing wisely. You'll see in this video, the American Academy of Family Practitioners, the American Board of Internal Medicine would agree with me. They, you know, these are the two, the guys that do the most stress tests are in internal medicine and family practice. The standards committees that look at this, even within those specialties, have said there are way too many stress tests being done. So go ahead and just hit the first 11 seconds, Gilbert.
My mom just recently suffered a heart attack, so it's pretty much high alert.
The health of my heart is always something that I have at the back of my mind.
Juana Lebedinsky has come to the doctor for a regular checkup. She wonders whether she'll have a screening test to check her heart.
That's good.
But Dr. Albert Levy does a careful...
So as you can see, again, we cover that in detail in the book. What do you do if you're a doc and the patient comes in and they're worried? Like Tim Russert came into his doc and said, you know, I'm worried. My blood pressure's going up. I'm still running, but is there something we can do? So soon as Gilbert gives us the water ball, we'll transition away from the program and into Q&A for today. So, Bob Weiss, good morning, Dr. Brewer. Caught COVID this week. CD and zinc killed it right away. Very pleased that managing our anti-inflammatory, I'm guessing you're saying CV inflammation, has stopped it in its tracks quickly. Thanks a lot. Well, thank you for sharing that, Bob. And yes, I think one of the most important things we can do in terms of protecting ourselves from COVID also protects us from heart attack and stroke. Thanks for making that connection, Bob. James Cantor. Bob, we hope you get better fast. Can you share how much you took of each? Vitamin C, D3, and zinc. Be well. Chuck K, thumbs up. Thank you. I appreciate the reminder, Chuck. If you guys could just give us a thumbs up, that helps the AI, the artificial intelligence, understand that this content is worth taking a look at. And it suggests it to other folks. James Osborne, I'm currently taking HCl with Pepsin. Heartburn raises my blood pressure. I heard you say in a video you're taking or took betaine. Is betaine better? So betaine is a source of methyl groups. If you've heard of MTHFR, Rutherford, or heard of methylation, that's what betaine is. It's a trimethyl something. Trimethyl. I'm having a lot of senior moments today. So here's the story behind betaine. It has to do with the fact that genetically, about half of us do not antioxidize very well. And that has led to a major set of theories, you know, the mitochondrial theory of aging. And basically what people think is that the mitochondria are the furnaces of our cell. If you compare us to lower forms of life like yeast, we get 36 units of energy out of a simple glucose molecule, for example, whereas the yeast gets 6 versus 36. How do we do that? Oxygenation. That is what hemoglobin's all about. It's about carrying iron, and the iron in the hemoglobin carries oxygen. Then we're able to burn things completely. Oxidation, another word for it might be rust, another word for it might be burning. So if you've got mitochondria, the furnaces of your cell, just like any other furnace, if you've got burning going on in it for 50 or 60 years, you're going to get some burning embers lying around, burning parts of the cell. And that's exactly what happens. And that's exactly a simplified description of the theory of mitochondrial aging due to mitochondria. Well, let's draw another connection. What part of the supplements industry is bigger than antioxidants? You hear about the antioxidants, usually A, C, and E. Well, the antioxidants are there to help us with this antioxidation process. At the end of the day, nothing helps like our body actually being able to do something for itself, but that's where Muthifer comes in, MTHFR. Our human body, instead of, you know, what's the opposite of oxidation? It's reduction or addition of a hydrogen atom. Our human body doesn't add hydrogen atoms back, it adds methyl groups, which is a carbon with 4 hydrogens. Pardon me if that got way technical, but that's the bottom line. That's what our body uses, the vitamin B complex, as a pool for methylated methyl groups. Those methyl groups then are what our body uses to accomplish antioxidation activities. Now, how did we get there? Again, betaine. So that's why I mentioned betaine. I have a little bit less than half of the metabolic methylation capacity that most of the population has. I'm not uncommon. Again, I say most, but up to half of us have challenges in that space. So that's what that's for. Thank you for asking, James. I hope that helps. Bambi Grage, great movie about Theranos and Elizabeth Holmes, the inventor. Thanks. I'll have to watch that. Sounds good. Fernando, lots of information, but no fix. Not sure at all what you mean by that, Fernando. Bill H., good morning, Doc. What are 3 to 5 medical journal sites that you would recommend for the state-of-the-art research that's also respected by mainstream or establishment medicine? Well, Harvard, you may notice I quote a lot from Harvard Health. Unfortunately, usually when I'm quoting from Mayo, I'm pointing out errors that they've made. If you look at the SEO and the popularity of medical sites, Mayo appears to be more popular than any of them, and it's got the great Mayo name. However, if you look at the content that's published by Mayo, you get a lot of mistakes, a lot more than you get with Harvard and some of the others. I think that's what's happened is that the folks at the Mayo information site probably have a lot more editorial freedom, and they probably have a lot more, again, writing talent and less science and medical talent. But again, Harvard Health is a good one. The Nature magazine is excellent, gets into much of the deeper science. I hope that helps, and I hope those aren't too technical. James Osborne, I'm taking 10 milligrams of ezetimibe. Does it have any significant anti-inflammatory effects? I've looked, but have found no studies that it does or does not. I haven't found studies that it does either. There are a few items that we know that have anti-inflammatory impacts. In terms of supplements, you have supplements like curcumin. Some of those that clearly have garlic have anti-inflammatory impact. In terms of cardiovascular inflammation, there are 2 medication groups that have cardiovascular anti-inflammatory impact. One of them is one of the groups that we all love to hate on, the statins. The most popular statin, Lipitor, doesn't have as much anti-inflammatory impact as some of the others. The 2 best ones are Crestor or rosuvastatin and Livalo or pitavastatin. Low doses are all that's necessary for anti-inflammatory impact. You don't need to have high doses. So if you're taking a high dose statin, you really should question that. High doses are set for focusing on LDL. Half the people that have a heart attack have a normal LDL. So it's just logically, how can LDL be driving as much of that as the medical community thinks that it's driving? The other drug category that helps with cardiovascular inflammation is ACE inhibitors. Ramipril, lisinopril, some of those that end with PRIL. So I hope that helps, James. And I will say this, putting those two together is multiplicative, not just additive in effect. Bill H., good morning, Doc. What? Well, looks like we've got some repeats there. Steve Andrews, would you advise meds over stenting for stable angina? I understand there's a nitro patch you can wear also. What's the long-term prognosis for stable angina? Yeah, again, I think that as you begin to see more and more of this information, lifestyle is clearly preferred. So we are getting to the end of our questions today. I appreciate the information. I appreciate the curiosity and the engagement that we've had. Gilbert?